Hi, everybody. In my previous presentation, shown as part 1, about the anesthetic management of patients with pheochromocytoma and paraganglioma coming for resection, I had discussed about the definition, etiology, pathophysiology, clinical features, diagnosis, and medical management, which is especially a pre-operative preparation, pre-surgical preparation of the patient. Today, we'll go beyond this. What you have to remember is basically the definitive management of these pheochromocytomas and paragangliomas is the adrenalectomy, because it is mainly an adrenal medullary tumor. So the type of the surgical intervention, whether it is laparoscopy or robotic or open, depends upon the size and location of the tumor. Very commonly, more than 80% of the patients undergo the laparoscopic procedures in modern times, mainly because it's also less hemodynamic changes, less catecholamine release, and there is faster recovery for the patient also. And there are two approaches, the transperitoneal approach and the retroperitoneal. Transperitoneal is mainly used for large tumors or bilateral tumors or in obese patients. As is usual, laparoscopy only limitation could be the risk of the pneumoperitoneum-induced catecholamine release, which can indeed precipitate significant hemodynamic changes. We'll come to that later. Open procedures are preferred for large tumors, more than 6 centimeters, invasive PCCs, that is pheochromocytomas, complete resection whenever it is required, or to prevent tumor recurrence or avoid local recurrence also. There have been multiple evidences now about the random, large-scale use of laparoscopic procedures. This is a study published recently where they compared laparoscopic procedure with robotic procedures with respect to the adrenalectomy. They compared the type of anesthesia with the risk of intraoperative hypertension and the type of alpha blockade and the beta blockers that was used, and whether it was TIVA versus balanced. When I talk about type of anesthesia, they found that TIVA use was associated with increased risk of intraoperative hypertensive events as compared to the balanced anesthesia. This is another study which is trying to compare the effects of robotic adrenalectomy in patients with pheochromocytoma as compared to the laparoscopic procedure. There are not too many evidences for them to check and compare. They said that at this point of time, no comment can be made on robotic procedures in terms of adrenalectomies. And laparoscopic adrenalectomies have also been found to be useful in elderly patients. So this was a study where they compared 54 patients. Of them, 15 were elderly and 13 were younger groups. They found that there were no differences in intraoperative hemodynamics and post-op outcomes. So what it means is the choice of anesthesia per se doesn't matter in terms of technique here. It is mainly in terms of the adequate depth of anesthesia, which is suitable or customized for each individual. So when the patient is posted for a laparoscopic adrenalectomy, it is important for us to review the patient status as is usual, especially with respect to blood pressure control and the cardiac status. We have to review the investigations, recent ones, and the review of the drugs that the patient is on, especially the alpha-adrenergic blockers, whether it is non-selective or selective, which I had discussed in my part 1 of presentation. Then when we talk to the patient, the preoperative period, we have to definitely counsel the patient and take a written consent from the patient for the procedure. I have added a section about the blood products here, basically because even though it is not frequently required, right? It could be required only when we have a large mass or when you think that it is anatomically difficult to locate for the surgeon. When you anticipate some bleeding, we may arrange it. But I want to highlight about the blood salvage in these patients, because when you talk about the blood salvage, either preoperative or intraoperative blood salvage, this blood is rich in catecholamines. And if you retransfuse this to the patient, there is a risk of hypertension in the patient. So there are considerations of this, especially in patients who are Jehovah's Witnesses category. Theoretically, you expect this hypertension to happen, but however, practically there are few case reports where patients with pheochromocytoma who belong to this sect have been managed successfully with autologous transfusion also, with preoperative or intraoperative collection. There are 4 important times at which we should be very careful in anesthetic management of the patients. For example, at the time of intubation, and you should be managing the pneumoperitoneum part when the tumor is being handled or when the draining vein of the tumor is ligated. So if you look at this data, for example, there is almost a 10-fold decrease in plasma catecholamines in patients who are not pheochromocytoma patients because there is stress of intubation. In pheochromocytoma patient, it can go up to 2,000 to 20,000 picogram per ml. And if you think about the gentle squeezing of the tumor intraoperatively or infarction of the tumor, look at the levels that it can go up to. It can go up to, I think, about 200,000 to almost, I think, 10 million picogram per ml. So there are certain preoperative considerations. Definitely, we don't want a situation where there is sympathetic stimulation and increased catecholamine release. So something related to anxiety, fear, stress, pain, shivering, hypoxia, hypercarbia should all be avoided or well controlled in the patient. So apart from counseling, you may use certain drugs, benzodiazepines, for example, as anxiolytics. There is no issue in general. But opioids, there are some issues with respect to the opioids. Pethidine, for example, has to be avoided and it can increase the heart rate. Morphine can potentially cause histamine release and which may provoke the release of catecholamines from the tumor. So that's the reason we should be very careful. This is a list of drugs which may be avoided overall. For example, ketamine causes sympathetic stimulation. We don't want to use. Thiophantom can be associated with tachycardia. It's ideal to be avoided in this patient. Desflurane is likely to be associated with tachycardia. Nitrous oxide, there are laparoscopic considerations, definitely like simple thing like PONV, to more significant ones like distension of the intestines and the greater risk of the embolism. Then rise in pulmonary vascular resistance are all considerations. Succinyl choline is more commonly associated with tachycardia. Pancuronium with autonomic ganglia block and tachycardia. Atracurium and mivacurium potentially cause histamine release and again catecholamine release from the tumor, and atropine for the extent of tachycardia it causes. So we can use more if you have got drugs such as remifentanil and fentanyl, we can very well use them because we can better titrate the dose to the effect, and there are favorable pharmacokinetics in these patients. And propofol we can use, but look at the volume status of the patient. It also has got benefit in attenuating the intubation responses of the patient. Etomidate is very useful, especially in patients with contracted blood volume, where volume status is of concern. Sevoflurane, isoflurane can be very well used with controlled ventilation and the MAC adjusted for individual patient. Dexmedetomidine usage has not been discussed, not much evidence about its use per se. But theoretically speaking, we should be thinking about the alpha-2 agonism produced by dexmedetomidine. Mainly, of course, it is central. And with respect to the alpha blockade produced by the drugs which are used in the preoperative control of blood pressure. What happens at the alpha-2, peripheral alpha-2 presynaptic effects? What are the interactions? We don't know. Of course, dexmedetomidine with magnesium has been used in a case of pheochromocytoma to control the arrhythmias in the preoperative period. They are found to be beneficial. Vecuronium, rocuronium, and cisatracurium are beneficial because they are cardiostable and they don't cause histamine release. Glycopyrrolate may be preferred over atropine because of lesser severity of tachycardia, which is induced because of that. Sugammadex, we don't have clear-cut evidences per se. So whenever we use all these inhalation agents or IV agents and all the drugs, we should also keep an eye on the renal status of the patient, which I said is also susceptible in a patient with pheochromocytoma. Ventilation has to be adjusted to the PEEP for each patient. So control the blood pressure based on PEEP also. We have to avoid the lateral planes and see that there is no exaggerated rate in the airway pressures. Avoid hypercarbia. Definitely there is risk of dysrhythmia in these patients. Temperature maintenance. So intraoperatively will be very important if there is an adrenergic surge in the patient. And positioning considerations, including the joint positions, the respiratory cardiovascular considerations related to positioning must be considered. For example, retroperitoneal approach would need lateral or prone position for the patient. And bilateral surgeries, patient is kept in the prone position. Intraop monitoring, there is a huge list if you can see here. For example, of course, the non-invasive blood pressure, SpO2, ECG, and all are there. I am not going into those details. ETCO2 monitoring as a laparoscopic procedure, it's very important. Carbon dioxide per se, which is used for laparoscopy, can stimulate the release of catecholamines from the tumor. And hypercarbia per se induces sympathetic stimulation. We have to be very careful. Neuromuscular monitoring, laparoscopy, we need greater depth of block. So there could be some electrolyte disturbances in the patient, if the patient is indeed on diuretics also. we have to have neuromuscular monitoring. Depth of anesthesia monitoring is very important. If there is later plane of anesthesia, there is greater release of sympathetic amines and hypertension risk for the patient. Cardiac contractility could also be affected with very deep planes of anesthesia. Central venous access would be required for fluid management in some set of patients, and of course, for administration of some vasoactive drugs in some selected set of patients. Arterial line is advised. Continuous BP monitoring is the advantage here, especially during critical times when, for example, tumor being handled, and you can also sample the blood for blood gases. So when I told you about the critical stages, airway maneuvers at intubation, tumor handling, and pneumoperitoneum, these are the times when the patient can develop hypertension. And when the venous drainage of the tumor is ligated, patient can go into hypotension. It is quite refractory to management. If there are hypertensive situations, clofazimine has been a very beautiful drug which has been available now and used. In fact, it is called as esmolol of calcium channel blockers. Short acting and very nicely titratable and has been very effective in these situations. And when there is problem with intubation and the responses, definitely we use the usual technique and drugs. We can still use lignocaine, short-acting beta blockers like esmolol and other things for management of hypertension at this point of time. The hypotension which occurs during the venous drainage, after the venous drainage is ligated from the tumor. So what will happen is there will be sudden precipitate decline in the plasma catecholamines in these patients. Plus, there could be a risk of residual alpha blockade with phenoxybenzamine and intraoperative fluid and blood loss. And if you think there is also increased anesthetic depth, it complicates the matter. So what we should be trying to do is we can have volume expansion before the vein is ligated. We can have replacement after hypotension, especially using ringalactate and normal saline. And we have to stop the vasodilator infusions if we have used previously. And we can indeed use alpha-adrenergic agonists like phenylephrine. And titrated reduction in the depth of anesthesia, which can help in increasing the blood pressure of the patient. It's also problematic sometimes with phenylephrine because there is reduced response to vasopressors. So peripheral, the phenoxybenzamine induced sustained deactivation of alpha-adrenergic receptors, which I spoke in part 1, could be a contributory factor here. Vasopressin would be a better choice because it acts on the V1 receptors and it therefore acts independent of the adrenergic receptors for the pressor effect. There is also risk of sudden decrease in the catecholamines with increase in insulin levels. We may need to add dextrose to the infusion after just before the tumor removal for the patient, and we can modify the insulin doses. There can always be critical cardiac events, including ventricular dysrhythmias or supraventricular tachycardias. We can use lignocaine, esmolol, and even magnesium sulfate has been used effectively. It has been reported in patients with Pheochromocytoma. For ventricular dysrhythmias, for supraventricular tachyarrhythmias, we can use amiodarone and beta blockers comfortably. So this is the report about the use of magnesium and dexmedetomidine, where it was found that it reduced the vasodilator requirement in the perioperative period management of Pheochromocytoma. What about the neuraxial blocks? So normally what we would think is if I had epidural, it's very beneficial for the patient. But it has been the one which has given opposite results in various evidences. It is found that the central neuraxial blocks do not prevent release of catecholamines from the tumor cells. In fact, hypertension secondary to catecholamine release during tumor manipulation, it is not attenuated by epidural sympatholysis. There could be exaggerated intraoperative hypotension and risk of hypotension due to chronic vasoconstriction if indeed by mistake you give spinal anesthesia to this patient. For example, this is a report, again, retrospective cohort studies, 3 sets of patients. 2 studies in this suggested that combined epidural and general anesthesia was associated with greater intraoperative and postoperative hypotension. Then this was another study, retrospective study of open resection of Pheochromocytoma. They found that epidural analgesia was an independent risk factor for early postoperative hypotension. And there was another study which talked about the same effect of combined epidural and GA. It was found that this was not effective in attenuating hypertensive responses, and in fact, it could be the factor causing exaggerated intraoperative hypotension. And there was a case report here of a 38-year-old male where they had used 35 ml of bupivacaine 0.5% epidurally. There are multiple episodes of hypotension in the patient, and of course, luckily, they could manage the patient. Postoperative care is very important here because we are all talking about the hypertensive status and the hypertensive status here. There will be continued poor vascular responsiveness secondary to reduced levels of catecholamines in the circulation. And there is risk of death also in some of the patients because of hypotension. We need to give large volumes of fluid infusion in the postoperative period also, and we have to titrate the vasopressors for each case separately. So we have to monitor, especially apart from the usual non-invasive monitoring, blood pressure, ECG, temperature, and pulse oximetry. Transthoracic echocardiography would be advisable for the patient to monitor the heart and the volumic status. And we can also try to always rule out the usual causes of hypertension like pain, right? The position of the patient and other things. In fact, it is said that even after the tumor resection is complete, majority of the patients, even though they become normotensive, they could overall have some raised blood pressure for some more time. They could be lower than the previous levels, no paroxysms. Overall, there is relief, but it is slightly maintained at a higher level in these patients. And some 50% can have sustained high blood pressure for days, and 25 to 30% have sustained high blood pressure long term also. So they need continued alpha blockade also. Normally, the plasma catecholamine levels will take about 7 to 10 days. If you get the blood sample done, we can see that it is done. This is mainly because there is slow release of stored catecholamines from the peripheral nerves. Steroid supplementation would be a consideration when we talk about bilateral adrenalectomy in some patients. So we can supplement the patient with, this is a protocol with respect to administration of methylprednisolone and IV initially, and oral maintenance with prednisone and fluorocortisone is advised for the patient. Glucose management, the third component, the heart, I told you heart is very important, the fluid management is very important, and the glucose management is very important. There could be sudden reduction in hyperrenergic status, so we have to monitor the patient with frequent assessment of the blood glucose and administer or stop or reduce the dextrose administration as required. In fact, 40%, about 4% of the patients can go into hypoglycemia in the immediate postoperative period. There is a controversy recently, especially which arose about 3 to 4 years ago, basically. Is alpha blockade really necessary? It's all of us know that we have been reading since decades that alpha blockade is mandatory, then it will be followed by beta blockade in the preoperative period. This was a German study in 2017, an observational case series, where they did not use the preoperative alpha-adrenergic blockade. They found that intraoperative maximum BP in those who received and did not receive the alpha-adrenergic blockade was similar, and there was no difference in complications between the two groups. And a French study 1 year later also, they said there is no need to wait for 1 week for alpha blockade. Immediate surgical intervention is advised. And then you can prevent and manage any intraoperative catecholamine events with the short-acting vasoactive agents. They also did not find any problem in the management of the patients. But overall, there has been no further accumulation of evidence, and we are happy to continue based on the evidences with respect to the preoperative alpha blockade. So in summary, the patients with pheochromocytoma may present with different types of manifestations, or it could be without manifestations also. And the type of the catecholamines that are released are also different among different patients. Preoperative preparation would consist of volume repletion, alpha-adrenergic blockade, normally with phenoxybenzamine or doxazosine, mainly because it is norepinephrine, predominantly secreting norepinephrine tumor. Balanced anesthesia would be advisable, and all the techniques and drugs would be used to prevent the stimulation of sympathetic nervous system, and adequate depth of anesthesia being maintained. Recent advances in terms of the diagnosis, as I told you, in terms of initial diagnosis and the localization of the tumor are very important in the preoperative period. Laparoscopy is the best technique, and usual laparoscopic considerations and the outcomes are also found to be better in this set of patients. And personalized management has come into vogue. So this could become a common thing because it is found that it has got a genetic background in many patients. So a teamwork of anesthesia specialists and the endocrinologist, surgeon and the ICU specialist becomes imperative in successful management of patients with pheochromocytoma posted for resection of the tumor. Thank you very much. These are the references.